Deprivation is probably one of the biggest threats to survival because, as a child, we're dependent on our caregiver for survival. So it's a huge threat.
When I think about neglect, we're talking about the neglect of not just, emotions, but it's a whole body, holistic deprivation from malnourishment of the body, impoverishment of connection and attunement. We're not having a social engagement system.
We know that 75% of the world's children are referred to protective services for neglect rather than abuse. So it's very vital that we understand this better.
You just heard from Doctors Ruth Lanius, Ebony Webb, and Karlen Lyons-Ruth, and they just described the profound impact that childhood neglect can have. Now, neglect can affect a patient in a number of ways, but many of those can be particularly subtle. So subtle, in fact, that your patient may not fully recognize that what they endured was neglect. Instead, they may say things like, "Sure, my parents were busy, but nobody ever hit me. My childhood wasn't that bad." But here's the problem with that.
I think, especially in thinking about neglect, it's easy to think, this isn't a dramatic kind of conflict that we have here. This is just a patient who didn't get enough, and that's clearly not a deep enough formulation about what's involved in these early abandonment issues.
Neglect may not always be as blatant as other forms of trauma, but as Karlen just said, it's crucial that we don't underestimate the consequences that it can have. So how can we effectively address an issue that can be so subtle yet deeply impactful? Hi, I'm Dr. Ruth Basinski, a licensed psychologist in the state of Connecticut and the president of the National Institute for the Clinical Application of Behavioral Medicine. And I want to take a moment to welcome you to the first session of NICABM's newest program on the treatment of trauma. Our understanding of trauma and how to treat it is always changing. That's why in this program, we'll be bringing you the newest thinking, the latest research, as well as leading-edge strategies to add to your treatment toolkit. In this first session, we're going to be focusing on the trauma of neglect. First, we'll get into the ways your patient might respond to neglect. We'll also break down the neurobiology of neglect, as well as what it can tell us about how to approach treatment. Plus, we're going to look at the impact of early childhood neglect on executive function later in life. Then we'll take an in-depth look at some key ways to conceptualize and approach neglect. We'll go through several different forms of neglect that you'll want to be aware of, and we'll give you specific questions that you might ask to assess for a history of neglect. And then finally, we'll walk through concrete treatment approaches for working with neglect. We'll pinpoint some precautions to take, as well as practical strategies that you can use when working with neglect. Now, before we jump in, I'd like you to take a moment to identify some of the patients you are working with who are dealing with the trauma of neglect. Make a list, and any time that we talk about concepts or strategies that might be relevant to one of those patients, make a note by their name. That way, you're going to leave with an action plan. So let's get into things. To start, what are some of the signs that might indicate that a patient has experienced early childhood neglect?
Neglect can often go with chronic parasympathetic hypoarousal. Because one thing to remember with neglect is that children often get punished in neglectful environments when they force the neglectful parent to pay attention to them. In neglect, there's a tendency for children to shut down. And so what we often see in survivors of neglect is less anxiety, less hyperarousal, less sympathetic arousal, and more parasympathetic numbness, disconnection from affect, and an inability to express themselves in words.
But why is hypoarousal such a common response to neglect? To answer that, we need to consider some key concepts about the nervous system. We know that when under threat, the nervous system tends to go into fight, flight, or freeze in order to escape the danger. But here's the thing. Because neglect can be so subtle, the nervous system might not rise to that level of threat response. Instead, over time, the nervous system adapts by going into hypoarousal. That's because with neglect, the nervous system is often responding to lack, not to threat. Lack of caregiving, lack of attunement, and lack of stimulation, for instance. Now, of course, that's just a general outline of what occurs. But if you have a gold membership to our previous trauma program, that's the Advanced Master Program on the Treatment of Trauma, then you might want to take some time to review that content, because that program might serve as a refresher of the many adaptive strategies that the nervous system might resort to. And like Dr. Janina Fisher just touched on a moment ago, one of those strategies might also be shutdown.
That's where the heart rate goes down, blood pressure goes down, the whole system shuts down. Often we lose voice production. And sensory information from the body and the environment no longer enter the cortex, so we don't know what we feel inside. And we've also lost connection with our external world. So we've disconnected from our body and we've disconnected from the external world as a form of survival. We also have a lot of endorphins coming online to protect us from pain. And, this is how our clients with a chronic history of neglect actually present, right? They're shut down, they're slowed, their cognitions are slowed, their movements are slowed, often their heart rate is low, and they're completely disconnected from their inside world. They're disconnected from the world. They don't make eye contact. And they're really essentially feeling dead to the world in the most extreme case.
Now, part of the shutdown might entail what Dr. Janina Fisher calls internalized neglect.
It manifests itself in difficulty with self-care, difficulty prioritizing themselves. I can remember one woman who ran a program at a major university who said, I'm supposed to call about my health insurance, and I can't make the call. And I've got a time limit. I've got to make that call. I've got to finalize which plan I'm choosing with the benefits office, and I can't make the call. And then she started to list all the other things she hadn't been able to do. She called it procrastination.
So that's just one example of how patients who have experienced neglect might present. Now let's take a look at this issue from a neurobiological perspective, because that can often help to explain the patterns of behavior that we typically see with neglect. Now we know just how crucial it is for an infant to have a nurturing and stimulating environment during their earliest years of life. But on a neurobiological level, why is that? I want you to hear from Dr. Margaret Sheridan. Margaret is an assistant professor in the Department of Psychology and Neuroscience at the University of North Carolina, Chapel Hill. Margaret's research is focused on how exposure to early life adversity is related to deficits in executive functioning.
The idea is that these early experiences, these enriching cognitive and social experiences that you have early on, are the sort of important inputs for the development of those parts of the brain. We have data that shows that if you randomly assign kids to more or less enriching environments very early on in life, that does affect the trajectory of their brain development long term, even through like 16 years of age, so into adolescence and late adolescence. And so if we think of the idea that you're going to enter into an environment where you don't require those complex neuronal connections that would allow you to sort of do that cognitive work later, then it's most efficient for your brain not to have them. So it sort of it's a system which is built to respond to the inputs that it's getting early on. And if one of the signals is you don't need all these connections, then this kind of nature of the brain is to prune them away.
So notice, if a child is experiencing neglect during some of their more formative years, it can mean that the regions of the brain involved in complex cognitive processes aren't being properly stimulated, and that lack of stimulation can inhibit the development of those regions. Now, before we go on, I want to mention that this program is designed for practitioners, but I know a portion of our audience is also made up of lay people, so I just want to address those watching who aren't practitioners. First of all, you are welcome here. And second, it's important to know that not everything we talk about here today will apply to your unique situation. You'll notice that I often say could or may or might. That's because I don't want to imply that traumatic experiences will always lead to certain mental health issues. And the third point, and this one is really important. The third point is that trauma doesn't have to be a life sentence. Even though trauma is devastating, it doesn't mean that you can't heal from the experience. And it certainly doesn't mean that it has to be the way that you define yourself for the rest of your life. Now, I want to get back to Margaret's research, and you just heard how neglect can inhibit development in certain brain regions. So now I want you to hear how that can lead to several behavioral consequences.
In a couple of studies, we've shown that if you look at very severe exposure, something like frank neglect exposure, all the way through these kinds of more like a lack of enriching exposures, you do see that the same brain areas are impacted and the same behavioral outcomes are impacted with regard specifically to executive function. In contrast, the presence of interpersonal violence early in life, we really see being related to emotional reactivity and the lack of regulation. We've seen this pattern now in our own work a lot, this differential impact of deprivation on executive function and threat on emotional reactivity. And we really think of those as being two separate things that both can contribute to psychopathology.
As Margaret just said, deprivation, like neglect, often leads to problems with executive function, whereas attacks, I'm talking about physical or sexual abuse, attacks are more often associated with emotional reactivity. More often, that is, not always. And I really want you to keep this in mind because in just a moment, we'll get into some findings that suggest one very important caveat to this. But meanwhile, here's the good news. Because of neuroplasticity, it is possible to reverse some of the impact of neglect on executive function.
We see that this period during adolescence is like a new time when, again, the brain becomes more plastic, and we can really expect to do some intervention there that can help adolescents meet adulthood with more capacity than they maybe entered adolescence into. There are many ways to compensate for these early experiences. There are skills that you can learn, and there are sort of ways that you can address these initial difficulties. In adolescence, you can do some rewiring of the brain, but even after adolescence into adulthood, knowing that your client has some difficulties around using cognitive control, I think can be really helpful in thinking about how to intervene with them.
Now, not only does neglect make it less likely that complex cognitive processes develop properly, but it can also affect the brain regions involved in attachment. So to help you make sense of this, I want you to hear from Dr. Marty Teicher. Marty is the director of McLean Hospital's Developmental Biopsychiatry Research Program, where he's primarily focused on the enduring effects of childhood maltreatment.
In terms of emotional neglect, you may have this one extreme where the individual is protecting themselves by not getting involved in relationships because they've been hurt too many times when they've invested their trust in a relationship. And so the parts of the brain that are involved in attachment and have developed to diminish the drive in some way for attachment as a protective mechanism. And these individuals will then, present later in life with all sorts of problems, forming and keeping a secure attachment.
If you are a neglected person, you develop a brain that can accommodate the neglect and doesn't expect to get more than you actually would like to get. What you see clinically is there is a lack of vitality and a lack of pleasure in your interactions. So we do get our sense of pleasure from having other people be engaged with us and other people responding to us. And so if nobody responds, that sense of vitality and pleasure tends to not be very well developed.
Now, that lack of vitality that Dr. Bessel van der Kolk just mentioned, that doesn't pertain just to patients with histories of neglect. We often see this come up for nearly all trauma patients. That's what we'll be looking at in the fourth session of this program. More specifically, we'll look at how to help these patients regain that sense of vitality and their capacity to feel pleasure. Now, here's the thing. When it comes to these neurobiological consequences of neglect, there's often an intergenerational component to it. To give you a better sense of what I mean by that, I want you to hear about some recent findings from research conducted by Dr. Karlen Lyons-Ruth. She's the director of the Cambridge Health Alliance Family Studies Lab, and she's conducted pioneering research on the impact of early maternal withdrawal starting in infancy.
If we look at the mother's childhood history, and we look at her childhood history of maltreatment, but we separate abuse history from neglect history in the mother. It's the mother's neglect history that predicts her disrupted behavior with her infant, that predicts her infant's cortisol elevations, and then predicts larger amygdala and hippocampal volumes. Notably, it's not the more hostile, intrusive behavior that is affecting the infant here. That seems to be not a factor in terms of elevating the infant's cortisol. But what it clearly underlines is that early lack of communication and neglect is a threat, not a deficit. We see in the stress hormone levels now that this is a profound threat for the infant. So, again, we have to think differently about neglect, I think, as having this really profound underlayer and of happening very early.
Karlen just raised a critical point. We might think of childhood neglect as a lack of care, but the neurobiological research shows that neglect isn't just a deficit. In fact, the nervous system often responds to neglect as a threat.
The abandonment is the emotional charge behind the neglect. And I think what we're seeing is there is an enormous emotional charge for the infant that's survival related to not getting adequate care in the first 2 years of life.
So far, we've looked at the ways your patient might respond to neglect. Plus, we broke down the neurobiology of neglect, as well as what it can tell us about how to approach treatment. And we got into the impact of early childhood neglect on executive function in later life. Now we're going to take an in-depth look at some key ways to conceptualize and approach neglect. We'll go through several different forms of neglect that I'd like you to be aware of, and we'll give you specific questions that you might ask to assess for a history of neglect. But real quick, if you'd like to have a recording of this program so that you can watch it again, you can do so by registering for a gold package. With the gold package, you'll get the audio, video, and transcript of every session in this program, and they're yours to keep forever. Not only that, you'll also get several bonus sessions, plus a complete set of learning tools that are focused on helping you apply the skills and ideas from each session in your work. And one more thing, your purchase supports our mission to share this program with practitioners in developing countries throughout the world without regard for their ability to pay. Not only that, but when you order by midnight tonight, you'll get the early bird bonus. It's a short, focused course on the neurobiology of trauma, and we brought together 5 of the top experts in the world to get their best strategies for working with the traumatized brain. To register, just click the link below. You can do so anytime during or after this broadcast, and when you buy it now, it's 50% off. So let's break down a few specific types of neglect that may impact your patient. According to Janina, it's often useful to distinguish between 2 forms in particular.
There is a huge difference between emotional neglect and traumatic neglect. Emotional neglect is usually the result of parents who are unavailable, critical, who believe the child should raise themselves, who are not really attached. Very, very painful. But traumatic neglect involves fear and threat. So in traumatic neglect, we hear clients saying, I was always hungry. There was never enough to eat. I remember one young woman said, yes, all 6 of us had to share one toothbrush when we could find it amidst the chaos of our home. Routinely, survivors of traumatic neglect report, we never had clean clothes. We never had clothes that matched. We never had clothes that were the right size. I remember one client who said, some girls made fun of my hair looking greasy when I was in 5th or 6th grade. And then I realized that most children had been taught to wash their hair by their parents. 2 clients that I can think of both described their primary parent, their mothers, leaving home and apparently to go shopping or to go on an errand, and then not coming back for days and weeks. So coming home to find no mother in the house was terrifying because it meant, how do we survive? And one, starting at age 8, was responsible for her 5-year-old brother. So the panic doubled. How am I going to eat? How are we going to take care of ourselves? And how am I going to take care of him? And the panic that it has left this client with is inevitable.
Now, Janina just used the terms emotional and traumatic neglect. And in just a moment, we'll get into why it can be relevant to approach cases from this framework. But I also want to emphasize that this is just one way of looking at this issue, because many experts would say that emotional neglect is traumatic. So to try to cut down on confusion, here's another way that you might think about this. What Janina calls emotional neglect has more to do with having a caregiver who was cold, distant, or detached. In other words, the patient's emotional needs were not met. On the other hand, we might consider traumatic neglect, as Janina refers to it. Traumatic neglect would be the neglect of basic needs like food, and safety, and cleanliness, and so forth. Now, take a moment to think back to those patients that you called to mind at the beginning of the program. And I'd ask you to consider which of these 2 forms of neglect might apply to each of your patients. And as we go forward, I'd like you to think about how you might integrate what you're hearing in this program in your next session with your patients. Now, of course, many patients may have experienced both of those forms of neglect. So then, why does this distinction matter? According to Janina, when it comes to emotional neglect, there are certain symptoms that notably don't tend to show up.
There is pain. There is a real blow to the child's sense of being of any value. But there isn't that fear and post-traumatic portion of what we see so often in our clients.
So those classic trauma symptoms like fear, intrusive memories, and hypervigilant, typically those are absent from cases of emotional neglect. Instead, with these patients, you might expect to see more of their struggles center around social relationships. Now, there are two disorders that are often associated with emotional neglect. But before we get into the first one, I want you to hear Marty's take on why these disorders often are linked to neglect.
The criteria for these disorders is that you have social neglect or deprivation in the form of persistent lack of having basic emotional needs met. And the reactive attachment disorder, you have an individual who is growing up and winds up not forming a clear relationship with a primary caretaker. And these individuals grow up sort of where contact doesn't matter. They're not comforted by contact. They don't seem to require contact. They're really disconnected from that way. And that's going to have potentially long-lasting impact in terms of their ability to establish, healthy, loving, supportive, caring, trusting relationships.
So we might consider reactive attachment disorder as a more hypoaroused response to neglect. But some patients might respond in a more hyperaroused way, and that presentation often leads to a different diagnosis.
In the disinhibited social engagement disorder, which is rarer, the individuals are so hungry for an attachment that they will attach to anybody. And you have a situation where these individuals will have no social inhibition whatsoever. So you see a child who will go up to adults without the slightest bit of fear or concern and engage with them. And on a superficial level, it seems quite charming, how they're, very, very comfortable talking to you, but they'll wander off with you just as readily. That doesn't seem to persist into adulthood, into that form, but I think it's going to lead to all sorts of problems with developing secure, healthy attachments later on.
Now, some experts would say that beyond this distinction between traumatic and emotional neglect, there are two additional dimensions that we may want to consider. The first one is what Dr. Ebony Webb calls malevolent neglect. This type of neglect is more caregiver-driven, where the caregiver has little regard for their child's emotional needs. To flesh this idea out a bit more, I want you to hear a couple of key examples from Ebony.
We have had families where their children were self-harming, getting blackout drunk because things were not locked up. And the parents are like, well, we need them to stop doing that. And so the first question is, are you willing to put your alcohol under lock and key? And I can't tell you how many of those parents will say, I don't think that that's realistic. I am not going to, live my life, have my friends over where I have to unlock a cabinet of alcohol simply because my child can't follow the rules. And I said, let me just rephrase this. You have a child that has identified that they do not wish to live. And this is their method of trying to kill themselves. And you are not willing to do whatever is necessary to preserve your child's life. What do you imagine they are making sense of that? How do you imagine that they're organizing that? And those are the families most consistently that I end up having to call child protection on. They're the ones. They are the ones because they are not willing to stop doing what they're doing. We have had families that have come in where the parents knew that their adult children, right, had molested their younger children and were still allowing their adult kids to come home. And these kids are spun out and the parents like, you need to fix the child because they're just being agitated. Oh, are they? So what we understand is that this particular child of yours has touched this particular person inappropriately. Are you aware of that? Well, yeah, but I mean, it was a long time ago.
Now, I want to point out that there are a multitude of reasons why a caregiver might treat their child this way. One of those may be that they themselves have a history of neglect. We touched on this idea earlier when we looked at some of Karlen's research. And as a reminder, we got into that maternal history of neglect and its link to infant brain development. Now, on the other hand, there's systemic neglect. This form of neglect is caused by factors outside of the caregiver's control. To give you a better sense of what I mean by that, I want you to hear what Ebony often sees in some of her community work.
We are working with inner city, multi-generational public housing families. They don't have the income to buy healthy food. You know, it's expensive to eat healthy. They bring their kids over to the group. And sometimes there's a really stark contrast that could bring a lot of judgment that the children look underfed and malnourished, and the parents often are morbidly obese. And so a part of that is the way that children process simple carbohydrates. They're more active. They're eating the same foods that their parents are, but an adult body, you know, eating simple carbohydrates because that's what's affordable will become morbidly obese. Okay. But we know that some of those children that come have high blood pressure, have high cholesterol at 5 or 6 years old.
So systemic neglect has more to do with living under the confines of a lower socioeconomic status. In these cases, a caregiver's income can be a barrier to consistently obtaining food and safe shelter. Now, before we move on, there's one more form of neglect that I want to highlight. And in some senses, we could say that this form of neglect overlaps with systemic neglect.
We could have certainly family neglect and parental neglect, caregiver neglect, but we can also have societal neglect. And that also has an impact in which people start to feel as though they have to do things in order to be seen, or that they have to just avoid certain circumstances in order to not feel left out. And so if I use the example of someone who is facing racism or sexism or homophobia or classism, there are ways in which we might choose to actually be around the people who will see us, who will recognize us and our experiences, and avoid the people who tend not to see those things about us. If we think that we're going to be around someone who's going to dehumanize us in some way, then we might, avoid those people. So these are adaptive responses in certain ways. But the problem is that we still lack that experience of being fully seen, accepted, and have a sense of belonging.
So you just heard several different forms of neglect, and I just want to summarize quickly each one of them so that you've got it. First, you heard the distinction between traumatic and emotional neglect. So emotional neglect, as the name implies, means the patient's emotional needs were not met. On the other hand, traumatic neglect might be considered the neglect of basic needs. We're talking about food and shelter, clothing, things like that. Then we got into malevolent neglect, which we called caregiver-driven neglect. Now, you might contrast that with systemic neglect, and that is caused by factors outside of the caregiver's control, such as low socioeconomic status. It could be that the caregiver didn't provide consistent care and nurturance because they were working 3 jobs, for instance. And then lastly, we got into societal neglect, where someone feels ignored or like they need to do something to belong to society. And examples of this might be when someone is facing racism, sexism, homophobia, or classism. Now that we've unpacked several different forms of neglect, let's get into some effective ways to assess for it. And as we dive into this topic, I want you to keep in mind what we've already discussed about just how subtle neglect can be, and how this may make it difficult for a patient to fully recognize that there was something dysfunctional about their childhood.
I don't think I've ever had a client come into my office and present as someone with a history of neglect. The evidence of the neglect tends to come out spontaneously over the course of treatment. It's usually not the presenting problem, because a survivor of neglect is unlikely to know I've been neglected.
So given the nature of neglect as Janina just described it, what are some targeted questions that you can ask to bring any history of neglect to the surface?
In the context of taking history, it often comes out. If we ask questions, the adult attachment inventory, with its questions about to whom did you go when you were in distress, usually elicits information about neglect if it's present. Often, the information about neglect emerges in the context of talking about the client's childhood. So I'm thinking about Annie, who said, well, of course other children didn't like me. And I said, of course? And she said, yes. I mean, look at us. There were 4 of us, and we all had clothes that were mismatched and dirty. There'd be a big pile of clothes on the floor, all different sizes, none of them clean or ironed. And we would dig through the pile to get dressed for school.
Beyond those specific questions, there are also a variety of questionnaires that you might consider using.
If you're working with a person who's an adolescent or an adult, there are lots of questionnaires that you can give people where they can really answer anonymously about their experiences. There are some really short ones that just quickly assess a set of experiences that would be consistent with maltreatment and neglect. And the child trauma questionnaire is one of those, which is widely available, that allows you to do that. It's pretty fast, and it's got good clinical cutoffs, which indicate whether or not something is likely to be considered neglect or abuse after further follow-up. Marty Teicher also developed a new questionnaire called the MACES. He's got different versions of it, a more complex long version and kind of a shorter version. In the shorter version, it just asks whether or not you've had a set of experiences. I think that one's freely available, and you could get that easily. And it asks a similar set of questions. There are also interviews you can do with children. So with younger children, there's an interview called the VEXR and another one called the MNBS. They're less widely used. I use them as research tools more than clinical tools, but they have sort of a way of talking with young kids about their experiences that I think are helpful. I think all of those interviews are reasonable to use down to around age 5. Like, you could use that kind of an interview technique around to 5, but younger than that, I'd be pretty uncomfortable that the kind of information you're getting might not be accurate.
Now, assessing your patient is just one aspect of neglect. It may also be relevant to conduct an assessment with your patient's caregivers, especially if you're working with a younger patient. In particular, you may want to get a sense of the discipline techniques that your patient's caregivers use. Because here's the thing.
Most parents are doing forms of discipline that happened in their own families and seem like the right way to do things. So it can be a really nice point of intervention. Just really specifically talk parents through what it is they do in different situations and then help them find new techniques. So even harsh discipline is associated with pretty negative outcomes for kids, and just helping parents find other ways, even if you're not specifically dealing with maltreatment, can be very useful for parents. We often don't assess that. We just give people new techniques without asking a lot about what they're already doing. There's also good questionnaires where I have found parents happily answer lots of questions that describe how they're currently thinking about discipline.
By now, we've looked at some of the ways your patient might respond to neglect. Plus, we broke down the neurobiology of neglect, as well as what it can tell us about how to approach treatment. We also got into the impact of early childhood neglect on executive function in later life. We've also taken an in-depth look at some key ways to conceptualize and approach neglect. We've walked through several different forms of neglect that you'll want to be aware of. And you heard specific questions that you might ask to assess for a history of neglect. Now, coming up, we're going to walk through concrete treatment approaches for working with neglect. We'll also pinpoint some precautions to take, as well as practical strategies that you can use with your patients. So when it comes to neglect, there's one crucial step that you'll want to take before diving into any complex interventions.
I feel like with neglect, the being noticed and tended to by the therapist is essential really before you start challenging the beliefs about deserving attention. Like if you just start going right in and challenging those beliefs, you deserve attention, you deserve to be cared for, and all of that, before you have helped them feel a little bit of that in the relationship, I think that's just going to be a dead end. It's just going to arouse too much, I don't like the term resistance, but too much objection, But it's much more difficult for it not to kind of break through that wall when you are tending to them in some way, just noticing, and you're aware how they were never noticed. And so you're making that the focus of the work. What happens right now when I see that you're a little scared. You don't have to go into the fear. Just, I think the danger is we try to go too fast into the fear or whatever, but it's the noticing that is the change agent. So I'm careful not to minimize that.
So that simple act of noticing your patient's emotional state can go a long way in establishing a strong sense of safety from the start. Now, this precaution around pacing, it doesn't just apply to certain cognitive behavioral techniques. You'll also want to be mindful of it when it comes to deciding when to move your patient into processing deep emotions.
It's very, very important that we understand with survivors of neglect that they will feel they're going to feel unmet and they're not going to feel attuned to if we're trying to get to their deep emotions, because they're going to be unable to.
The idea of, let's open up to feelings. Let's connect with these things that have been pushed out of awareness and become, fully alive and fully integrated with our emotions. Or let's really learn how to interconnect with others. Those may all be important parts of our healing journeys, and ultimately may be part of a healing journey for somebody who's been very neglected, but not at the outset. It's really not going to work well. Reassurance, for example, does not feel real when people don't have a template for it, when they don't have it's okay, sweetheart, feeling somewhere inside. Us suggesting that they're okay, it falls on deaf ears because they don't have a framework to take it in.
Now, that clip that you just heard from Dr. Ron Siegel, that comes from the Focus on Application session. Those sessions are designed to help you take the ideas and strategies from this session, as well as each of the other sessions in this program, and integrate them into your practice. And they're one of several learning tools that you'll get when you register for a gold package. Not only that, but your registration for the gold package allows us to keep making programs like these. It took us 2 years and thousands of dollars and many staff hours to make this program. And your gold membership helps us keep going. To sign up, just click the link right below. You can do so at any time during or after this broadcast. Now, I want you to think back to the beginning of this session. Janina shared a case study about a patient who was struggling with self-care. And because of this, she had a difficult time getting herself to renew her health insurance. I want to return to this case study because here's the thing. This precaution around accessing deep emotions often applies to patients who present with hypoarousal. And as we talked about earlier, these patients often come across as disconnected from their emotions, sometimes to the point where they lack the language to describe what they're feeling.
And I'm remembering she and her husband used to argue because he would say, why can't we have time together? Why can't we have time to cuddle together, to have sex, to have some closeness in our relationship, which she agreed was a wonderful relationship. And she couldn't because there was always something more important to do. And it was very, very important for her that I understood what was happening. It wasn't that she didn't love her husband. It wasn't that she didn't have feelings of closeness toward him. But she couldn't help herself from neglecting the relationship. And she needed me to understand why she couldn't feel more toward this man that she loved so much. If I had instead tried to help her connect to her emotions, she would have felt unmet, and she would have felt that she was doing something wrong. Because it's quite obvious to clients when we're seeking that connection with emotion. It's not lost on them that we want them to feel. But survivors of neglect often can't feel.
Now, beyond these precautions around pacing, it's also important to be mindful of the types of skills that you're giving your patients. What do I mean by that? According to Margaret, when it comes to these patients who have had neglect, it means you might want to reconsider how much focus that you place on de-stressing or on calming skills.
Our interventions for stress tend to be things like relaxation, teaching people calming techniques, sort of teaching people to relax and be less stressed out. We've talked a lot about sort of self-care, of trying to help people kind of think through calming, giving themselves like less stress. And I think if we instead think that part of the deficit is really like a cognitive regulation deficit, a deficit in holding in mind goals, stopping yourself from things you don't want to do, that's actually a pretty different target. And that telling people to relax and helping them to relax won't actually address that target. And I think of some public health interventions in schools where it sort of is a public health intervention around de-stressing. And I'm not sure that that's really the right thing for us to be addressing.
So think back to earlier in the session when Margaret talked about her research that showed that some folks who've experienced childhood neglect have a deficit in executive function later on in life. Here are some strategies that you might use to help your patient improve their executive function.
If we have adolescents and adults in our practice with a history of neglect, we might want to help them think about actually working harder to hone their skills around regulation. So finding tricks to remember their goals when they're going to be in a moment of emotional distress, sort of pretty kind of structured cognitive interventions that can help people do the cognitive processes that they need to do to regulate themselves, and a little less of a focus on kind of calming or stress reduction, and kind of more of a focus on the sort of like imparting new skills or imparting skills around kind of cognitive regulation. Thinking about how to hone your cognitive tools around attending differentially to stimuli, around how to tips about how to hold in mind your goals in the face of new information, how to sort of tips about how to actually use cognitive processes to control your behavior and to give yourself a pause before you react. Things that you might not think of as targets of intervention, I think can be really important if people have experienced neglect, because that might be precisely where the deficit is.
So we've just looked at several precautions for working with neglect. Now I want to get into where you might actually start in terms of treatment. Earlier, Janina talked about how patients who've experienced neglect often struggle to get in touch with their emotions. So how can you ease patients into being mindful of what they're feeling without going too deep, too fast?
Often I start by just having the person notice, what they feel inside, and to get them in touch with the fact that often they describe this numbness, this inability to feel. I may ask them, do you ever feel like a robot? Does it feel like your feelings are anesthetized? And, often they can connect with that. And that's sort of the first tiny little step that, oh, maybe she understands just a tiny little bit about what's happening inside me.
Now, there's another point of contact that patients who have experienced neglect often struggle with, and that is eye contact. And in addition to working slowly and respectfully, you'll want to be mindful that eye contact can elicit powerful emotions, including shame. So here's a titrated approach that you can use to help your patients increase their ability to maintain eye contact.
So just very respectfully, asking about what is it like to make eye contact, and that's okay. And we're going to move at a pace that feels safe for them, one step at a time. And, maybe ask for permission. Is it okay if we track, throughout our sessions, your ability to make eye contact? And so those are usually 2 ways in. And then if I feel the client is ready, I may actually say, if you feel ready, would you be okay just trying to, change your posture from being collapsed and looking down to just looking up and having your head straight? And I also ask them, would this be easier for you if I closed my eyes, for example? And if you feel you could do this, if I closed my eyes and didn't see you, please go ahead and ask me to close my eyes. And I usually get half and half responses. Half of the clients ask me to close my eyes, and then, they raise their head and they look up straight. And then I ask them with my eyes closed, so what's that like for you? And I've seen so many times that this is a true epiphany for people, who've had this downward posture, and to now change this and say, oh my God, I didn't realize what I was missing. And then over time, we would work towards them feeling safe enough for me to have my eyes open when they do this. But I think that self-experience of changing your posture, of changing, how you hold your head and keeping your head straight and actually being able to see what's around you is often incredible when you're used to being collapsed and not making eye contact.
Now, this difficulty with eye contact that trauma survivors often experience, there's neurobiological data to explain why this happens.
Several years ago, our group did a study where we had an avatar that looked directly into people's eyes versus overtly. And in individuals who hadn't been traumatized, when that avatar looked directly into their eyes, they activated higher areas involved in social connection. Those areas of the brain that help us to know what the other people feel, what other people's intentions are. And so that really makes it safe for us to connect, right? If we can read another person emotionally. But in the PTSD group, in individuals who'd been severely traumatized, there was a very different picture. And all those individuals activated in response to having this direct eye contact by the avatar was that they activated the innate alarm system. So a deep part of the midbrain, the survival brain, that deals with threat, that deals with escape. They didn't activate any of the higher areas of social connection where we know what the other person feels, where we know what the intention of others is. And so that was really eye-opening for us. And that taught us, that this is a critical circuitry in the brain that we need to bring online in response to therapy. But it also really validated what we were seeing, and it really validated what our patients were experiencing, right? This terror of making eye contact. And this was then further validated by what our patients were telling us. Our clients were telling us, whenever I looked into my mother's eyes, for example, I was at risk of being hurt. My mother didn't want me to exist. She couldn't bear to see me. Whenever she saw me, I got hurt. So I learned very early on to look down, to disappear was the only way to survive.
So I want you to keep Ruth's study in mind and think about how you might apply it to your practice. For example, you might reconsider how you set up your office chairs to help patients who struggle with eye contact. Now, to give you a more concrete idea of how you might use the strategies that we've talked about so far, I want to turn to a case study. For that, we're going to hear from Dr. Pat Ogden about her work with a patient named Carly.
So when Carly came to me, she didn't have to speak before I knew she was neglected. And the reason for that is that she had a look about her of not caring about herself. She talked very, very softly. She was very tentative in her movements, a little bit collapsed. There wasn't much affect in her prosody. She came to therapy as if she didn't expect anything.
Now, this case is a prime example of an idea that we've come back to again and again in this session. Many times, patients who've experienced neglect won't come into therapy and disclose outright what they've been through. Rather, their neglect history often shows up in more indirect ways. Whether that be a lack of hygiene, a collapsed posture, a dull presentation, or a meek way of talking. As Pat began her intake with Carly, she learned that Carly had experienced both physical and emotional neglect growing up. And throughout their work together, Pat noticed a recurring theme. Carly would often hint at having a deep desire to be close with her therapist. So how did Pat address this?
We explored proximity and distance, but she almost felt as if she couldn't take an action towards another person. Like when we talked about what if you came a little closer, what would that be like? And she was like, oh, I can't do that, and she wouldn't reach out towards me. But I moved forward to her, and that meant that was huge for her. Just that I would do that, I think what she said, that you would want to do that you would even move closer. And that, that just tells us of the depth of her feelings of lack of worthiness, not deserving care, not deserving someone attending to her. And attending to her is very different from from the attention seeking of abandonment. It's just this, somebody notices me, somebody is tending to me, somebody sees me. It's not this demand for attention. That was never there.
Notice the difference between neglect and abandonment that Pat just pointed out. In cases of neglect, there is a lack of attention seeking. Now, next session, We're going to get more into this topic of abandonment trauma, and what we talk about in that session will build on a lot on what we discussed today. So be sure to tune in next session, because I think it will give you a fuller picture of how to more effectively approach and treat both childhood neglect and abandonment. Now, I'd like you to hear the steps that Pat took to help her patient.
To help her heal, I had to demonstrate that I could tend to her. So every time really that I contacted, her experience was really significant for her. Like, even if I said, "You seem a little sad," that was huge for her, because it was just nobody had ever noticed anything about her. So I found that just those little kind of tracking little statements that said, "I see you, I notice you," that was really healing for her. We spent a lot of time with those small little, I would call them missing experiences that someone noticed. How does that settle? What happens? Well, I took a little breath. That's great. Just stay with that breath. Stay with, I'm with you. I'm noticing you. I see that you're sad. I see that you're pulling back. I see you. And then that moved to, of course, experiments with actually seeing. Like I closed my eyes and then I would open them, and we would experiment with that. And I would say, I see you. You're here. I see you. To some other client to say, "Oh, you seem sad." It's like, that's expected. It's expected you notice that they're sad. And it just doesn't have the meaning. But for this client, she didn't have that expectation. She didn't expect anybody to notice it.
So notice, Pat's first step was to simply observe and name what her patient had been experiencing. This tracks with what we've talked about just a few minutes ago, about how important it is to be attuned to your patient before you dive into deep processing work. Where might you go next? Here are a few ideas.
One of the things we did was I had a shawl, a long shawl that she wrapped around, and I pulled the edges of it to give her that sense of containment coming from me. And she loved it. She just loved it. I wasn't quite comfortable actually holding her, because I didn't feel she was present enough with herself to be able to integrate physical contact. I just wasn't sure. So, but that was a good substitute. Another thing that was important for her was this, like reaching and taking in. Like I know we worked with a gesture of like this, of taking in for herself, like a movement that says, I can receive, I can take in. If something's offered, I can take it.
So you've just heard several exercises that you might use to help a patient gradually become more comfortable with being cared for. And as you've listened, I hope you've made note of how you might apply these strategies with your patients. Because here's the thing, all the training in the world won't matter if you don't put it into practice. So please, go right now to the comment board to share how you'll be using the ideas from today's session. Let us know your biggest takeaway from what you just heard, and be sure to take a look at how other practitioners plan to use these ideas with their patients. It might just spark some ideas for you. You can find the link below. And I just want to close by saying that what you do is so important. I believe that when you help someone heal from trauma, you change the course of civilization. That's because it's not just that person's life that changes, but that healing can also have an impact on their spouse, on their children, and their friends and colleagues. And that can ripple out to their community, to their state, and then to their country, and eventually to the world. Thank you for what you do. I'll see you in the next session. Until then, Please take care.